ABG report. According to that, we are deciding whether it required patient ventilation or not. Now, your important is the venous connection. What you used to do, sometimes you all have felt that when there is a swelled body, you are not able to get a vein. Very difficult. We have tried 25 times. So what you do to practice in earlier days, you used to do the venesection. Even sometimes in surgical you need venesection. You are cutting two vein and then connecting cannula and putting in. Nowadays venesection is generally not being practiced because central venous line is the line of choice, and it is being hardly required 10 to 15 minutes. We can do it through the central venous line application. So this is the set. This technology last 30 years been practiced for various cardiac intervention, and here you see the various central line is normally what are the central vein? There are three central vein commonly being used. One is the jugular vein, second is the subclavian vein, and third is your femoral vein. These three are known as central vein. So either the subclavian vein or jugular vein or your femoral vein been practiced. Okay, all the procedure of venous through reaching right heart we used to do from that. Mostly temporary pacing or CVP monitoring, central venous pressure monitoring, all has been done through this line. So this technology is developed, is known as, anybody? This technology is the puncturing first, followed by this procedure known as cell danger technology. Whole thing is the same. First you put a needle, puncture the vein, followed by guide wire, followed by dilator, seat. Dialysis sister is there, na? Sister ji, अभी आप कहाँ चले गए? हाँ, but you used to do ना? देखते हैं वहाँ daily. First puncturing, followed by needle में guide wire, and guide wire is followed by sheath. Okay, dilator देख के sheath, and then you remove the guide wire and needle. So this is the ideally technology is known as who developed is cell danger. So whole intervention is now based on the same technology, cell danger technology. That you have to puncture it first, followed by puncture it. This is the needle. When you are puncturing the vein, put a guide wire. This is the guide wire. Just after puncturing the vein, you are putting the guide wire, and guide wire is followed by your dilator, and dilator is followed by sheath, and then you put the guide wire, and then sheath to be remain. So there are multi-channel sheath, 1, 2, 3, sometimes 2, sometimes 3, sometimes multi. Again you connect Y connection. So you have a 4-5 types of line. No problem for venous lines. But to whom it should be done? For those who have a different your monitoring. One, you are not getting vein. Second, CVP measurement. CVP means central venous pressure. How many fluid you want to give? So there is a CVP manometers. We are now disposable CVP manometer, hardly 100 rupees something. You can use CVP and dispose it. That is CVP. How many fluid you have to give? 4 liter, 3 liter, 2 liter. Suppose severe dehydrated patient, CVP less than 8, then you give more fluid. If there is a over-hydrated patient, you give less fluid, restricted fluid. So that whole line is known as your CVP line plus nutrition, intraparenteral nutrition. Long-term patients require CVP line, central line. Dialysis patient or your heart block temporary patient required this. So CVP line, central line is now a reality. There are days of the venesection has gone. No need for vein because you are inviting more infection, and you are getting hardly not a multi-purpose line. Here you can get 3-4 lines. At the same time you can do one side intraperitoneal nutrition, one side you can JB2 monitoring, and peripheral lines you cannot do the monitoring. So multi-para monitoring is required. So this is the cell division technique. All the practices for cardiac intervention used to this practice. There are many merit demerit that is not your part sometime. What are the hardware you have to check it. Everyone should acquainted what to fast, what to second, because used to the sometime emergency patient, midnight 12, patient on the recurrent arrest, and in that time it is very difficult to give you 2 minutes, 3 minutes time. We have to puncture it. My sister has to give me all the thorough one by one immediately, because you don't have time for that. So correctly, and if you are doing somewhat negative, angle will go immediately, pneumothorax will happen, lung will puncture. So your angle should be everything all right. Then how to wash the lines, because it will invite the air embolism. So central line mein you have to very much cautious for. Heparinized clot should not go. That will lead to this. So what are the care when you will discuss yourself in next central line? Those sisters will volunteer to speak on central line. They have to tell you in details what are the complications of central line, how to care central line, what are the how to infection control, what are the day-to-day care of the central line. So this is a very important nursing care for regarding the central venous line. So subclavian most safe, followed by jugular, then femoral. Femoral is not a good choice for long term. For short term, when there is no other, then we have to go for line. So these are the important line for this. Similarly, for pacing patients, this is the important gadget for your. This is the pacemaker pulse generator. This is the external pacemaker pulse generator, and this is the basically pacing lead. You look for that. This is the pacing lead, and this is the your generator. There are many marker different type of machine. When there is a suppose patient, just 10 days before, 5-7 days, today we are going to discharge. One of our OT staff, Bindu, cleaning sanitary worker, her mother came with 5 to 6 times a systole. There was complete a systole, again a systole. We receive with 40 days, 3 to 5 times. Immediately same day at 12:30, 4 o'clock we are given the TPI followed by permanent pacemaker. Today we are discharging. So in that type of patient, first we have to put the TPI. This is known as temporary pacemaker. Once TPI, suppose midnight they are coming, at least we can save the life through the putting up inside this TPI, and then as per plan we are going for the permanent pacing. So temporary pacing, complete heart block, or any patient whether there is a recurrent syncope, pulse beat is less than 40 pulse beat with syncope is a danger sign. Whenever you are detecting 40-50 rate and with the syncope, it is a danger sign for us. This whole line and this will be better. This is the basically, you see, central line, only thing this, what we are doing, this machine is known as Siam machine. What is sister saying, the orthopedic procedure has been done in different areas. What we are seeing under this guidance, fluoroscopy, this is the fluoroscopy. Now there is a modification in the various machines. So when you are learning the gadgets, basically how many machines hospital for it. Siams have many modification. From Siam to cath lab machine. This is the cardiac machines for the different procedure. Here we can see the different parts. Particularly it is good for right heart procedure. Left heart mein mostly we are doing for the Siam complete cath lab machine. Whether angioplasty or will be done from the arterial side, but venous side we can do. So many works from the right heart side activity through Siams. TPI, PPI, central lines, different valvular status of the patient we can see for that. So those who want to, how it looks, what to looks, any sister is interested, we can't come and you see we are doing the procedure, we can see the various use of Siam and how we are doing this. So this is the important area. as I told you, after TPI, you used to see the permanent pacemaker. Now it is a only 22 gram weight machine. It is not a high machine. The permanent pacemaker is doing for those patients, whether for heart patient, heart block patient, yeah. It is a hardly look like a coins. And every year, so many cases used to do. It look, it is a like this patient, and even a smaller. This picture is bigger, and one lead is being placed, and the heart is going tricuspid valve, reaching at the apex, and then stimulating it. And then you are closing here and through this. And how this lead is being put inside heart? Through the puncturing your subclavian vein. So through PLI, percutaneous lead insertion, used to give for the ear. So this, up to this work, whatever you have seen, it is available in our hospital. But some other advancement has been come for the like coronary angiogram. You see cardiac, one cath lab I was discussing. Here what you are seeing, you are putting a dye inside the artery, coronary artery, and seeing the flow of this. This is known as coronary angiogram. And then you are seeing if there is blockage or not. So if there is a blockage inside this, suppose this is LAD or LCX, there are right coronary artery, left coronary artery. So right coronary artery again divide two. So this is the important to see the various blockages inside this. So then you can assess what are the blockages. And if there is a blockage, what is the treatment? Is known as angioplasty. What you are doing in angioplasty? You are putting inside the first guide wire, again similarly cell injury, a small guide wire, and then balloon, and then followed by balloon, say dilate, you are dilating, and followed by last you are doing the stand, now it is standing, so that it should not get collapsed again. So this is known as angioplasty. Similarly, if there is a multiple blockage, like you see here, multiple blockage, then that is to open heart is being done, is the bypass surgery. You are seeing, you are putting two grafts, the blocked artery, and in front you are putting a graft. So there are many grafts. You can discuss the post-operative care of PTCA and bypass in your own lecture in future, because so many bypass patient angioplasty we are following on, and we are sending for and bypass surgery, and returning again we are seeing. So huge number of patients is coming. So how it looks, what are the care, what are the to be care, particularly for first 2-3 months, 4 months, we used to see. So these are the common activities in most of the throughout the world. These are the activities for the cardiac gazettes related to what is our talk was related to cardiac instrumentation and its use, common use, why you are doing, what are the care, when we are doing, these are the indications. So basically today our talk related to your gazette. We have started this continuous medical education for nursing staff. Now it is a ever changing job. I told you from initial what we are practicing in 90s, in 20,000, everything is now changing. The way has been changed.